Chapter 50, Renal and Urologic Problems. Let's start with infectious and inflammatory disorders of the urinary system. A urinary tract infection, or UTI, is the most common infection and second most common bacterial disease in women. It's caused by many things, most commonly E. coli, though it can also be caused by Candida albicans, indwelling catheters, or asymptomatic colonization. It may also be due to fungal or parasitic infections. There are many classifications of a UTI, from the location being the upper renal parenchyma, pelvis, or ureters, to systemic spread such as urosepsis, which is life-threatening. There also may be uncomplicated, meaning it's only localized to the bladder, or complicated, occurring within structures or functional problems within the urinary tract itself. Here in Figure 45-1, we just have the sites of the infectious process in both the upper and lower urinary tracts. In the urinary tract, or above the urethra, there may be defense mechanisms such as complete emptying with voiding, a ureterovesical junction competence, ureteral peristalsis which propels the urine towards the bladder, an acidic pH, a high urea, or glycoproteins that inhibit bacterial growth. There are many risk factors for a UTI, including obstruction, retention, renal impairment, foreign bodies, anatomic factors, a compromised immune response, and functional disorders, just to name a few. By the pathophysiology, organisms from the perineum ascend the urethra. Within the GI tract would be gram-negative bacilli, and contributing factors include urologic instrumentation and sexual intercourse. UTIs are the most common healthcare-associated infection, and these are due to catheter-associated urinary tract infections, and also increase with the length of stay, cost, and mortality of each hospitalization. Lower urinary tract symptoms include emptying symptoms such as hesitancy, intermittency, post-void dribbling, urinary retention, and incomplete emptying. There also may be storage symptoms such as urinary frequency urgency, incontinence, nocturia, or nocturnal enuresis. They may also present with hematuria or a cloudy urine. Upper urinary tract symptoms include flank pain, chills, and fever. They may also go along with fatigue, anorexia, or even be asymptomatic. In older adults, the classic manifestations are absent, and will include non-localized abdominal discomfort, cognitive impairment, or generalized deterioration. That's actually a very common classic NCLEX question, where you'll have an elderly patient who's suddenly confused, and they're queuing you in for a UTI. Diagnostic studies could include an initial dipstick for nitrates, white blood cells, and leukocyte uterase. You also may order a urine culture or sensitivity, and a thorough history including recurring UTIs for more than 2 to 3 a year, complicated UTIs, CAUTIs or HOTIs, meaning catheter-associated urinary tract infections, or hospital-associated urinary tract infections, UTIs that may be unresponsive to traditional therapy, and they may also order imaging such as an ultrasound or a CT scan. For interprofessional care, we're going to get a thorough history and physical, along with a urinalysis, and managing an uncomplicated UTI would include patient teaching, adequate fluids, and drug therapy, such as antibiotics. For recurrent UTIs, it would be all of the above, plus susceptibility testing, and a possible suppressive or prophylactic antibiotics. These antibiotics could last for 7 to 14 days or longer. For drug therapy, when dealing with uncomplicated or initial UTIs, drugs like trimethoprim, ampicillin, or if it's fungal in nature, fluconazole. We're also going to be looking at urinary analgesics. Our subjective data, again, is going to be a thorough past medical history, looking at the patient's medications, previous surgeries, and their functional health habits, nutritional and metabolic intake, elimination, looking at their I's and O's, if they've been having urinary symptoms previous to this. While our objective data is going to be a general assessment along with a thorough, focused urinary assessment and looking at any possible diagnostic findings. Our nursing diagnoses would pertain to things like impaired urinary system function, acute pain, and planning goals such as relief of bothersome symptoms, no upper urinary tract involvement, and especially no recurrence. For health promotion, we're going to recognize at-risk patients. and patient teaching such as emptying the bladder regularly and completely, evacuating the bowel regularly, wiping from front to back, and maintaining adequate fluid intake. Another major danger is going to be those catheter-associated urinary tract infections. To prevent this, we want to avoid any unnecessary catheterizations, early removal of indwelling catheters as soon as we can, and also include things like aseptic technique, thorough hand hygiene, and gloves for catheter care. For acute care, we want to maintain adequate fluid with dilute urine that reduces irritation. Also, avoiding any irritating foods or fluids. Apply a heating pad to the suprapubic or lower back, well with a warm shower or bath, and include patient teaching such as the drugs and their side effects, and what to look for improvement and what symptoms to report to their provider. For ambulatory care, we're going to take our antimicrobials as ordered, as well as adequate fluid intake, and voiding regularly before and after intercourse. Also, stopping using any diaphragm temporarily until symptoms subside. Our expected outcomes: the patient will have normal urinary elimination patterns, report relief of any bothersome urinary tract symptoms, and state the knowledge of the treatment plan. Moving on to acute pyelonephritis. It involves an inflammation of the renal parenchyma as well as the collecting system. It's most commonly due to bacteria such as E. coli, though it could also be fungal or protozoal or even viral in nature. Here in figure 45-2, we just have a photo of what that acute pyelonephritis would look like. Pyelonephritis is the initial colonization and infection of the lower urinary tract from the urethra. It could also be due to pre-existing factors such as vesicoureteral reflux, where the urine moves from the lower to the upper urinary tract, or dysfunction of the lower urinary tract due to an obstruction, stricture, or even a stone. It may even be secondary to things like a CAUTI or pregnancy. For our clinical manifestations, the classic symptoms are going to be fever, chills, nausea, vomiting, malaise, and flank pain. It could also present with dysuria, urgency, frequency, or costovertebral tenderness. Our diagnostic studies would include a urinalysis looking for things like pyuria, bacteria, hematuria, or white blood cell casts. We would also include urine cultures and sensitivities, blood cultures, as well as decreased function tests and ultrasounds and CT scans. The mild symptoms could be treated in an outpatient or a short inpatient setting, would include fluids, NSAIDs, and follow-up cultures and imaging. We would also have severe symptoms as above that would also include IV fluids until oral is tolerated, and a combination of parenteral antibiotics. In the case of relapses, it would be 6 weeks antibiotics, or for recurrent, the patient would be on prophylactic antibiotics. In the case of urosepsis, we're going to monitor for and treat any septic shock to prevent irreversible damage or even death. Subjective data, again, that thorough health history, medications, surgeries, and their functional health patterns, elimination, nutrition, fluids. This would be included just as before, with general assessment followed by a focused urinary assessment and any appropriate diagnostic studies. Our nursing diagnoses would include impaired urinary system function, acute pain, and lack of knowledge. The patient will have normal renal function, normal body temperature, no complications, a relief of pain, and no recurrence of symptoms. Our health promotion and maintenance is going to be similar to UTIs, and we want to focus on early treatment to prevent that UTI from spreading and ascending up to the upper urinary tract. Patient teaching would include the disease process, taking medications as prescribed, follow-up care, the signs and symptoms of relapse or recurrence, and adequate fluid intake again, 8 glasses of water a day, as well as rest. Our expected outcomes: the patient will have normal urinary elimination patterns, report relief of bothersome urinary tract symptoms, and state knowledge of treatment plan. In the case of chronic pyelonephritis, the kidneys become inflamed, causing scarring that leads to a loss of renal function. This results from anatomic abnormalities or recurrent infections of the upper urinary tract. For our diagnostics, it's going to be a radiologic imaging and biopsy. And the treatment would include treating the infection as well as the underlying contributing factors. In the case of urethritis, this is going to be an inflammation of the urethra due to bacterial or viral infection. Should a urethral diverticula develop, the incidence is more common in women than men. The urethral trauma could be the cause, instrumentation or dilation, vaginal deliveries, or frequent infections. The symptoms would include dysuria, post-void dribbling, frequency, urgency, suprapubic discomfort, incomplete bladder emptying, incontinence, asymptomatic with females, as well as hematuria, cloudy urine, vaginal wall mass, or even purulent discharge. When diagnosing a urethral diverticula, it'd be diagnosed with ultrasound or MRI for imaging, or even with a scope, and the treatment's going to be surgical in nature. Interstitial cystitis, or painful bladder syndrome. This is chronic, painful, inflammatory disease of the bladder. It presents with urgency, frequency, bladder and pelvic pain, or urinary pain not attributed to other causes. The etiology is unknown, though it could be from a variety of factors from neurologic, mast cell changes, infections, or toxic substances in the urine. The primary clinical manifestations are pain and bothersome UTIs. The severe is going to be where they void more than 60 times in a day to night. And the pain's usually suprapubic, but may involve the perineal areas. They increase pain with bladder filling, and that postponed urination, physical exertion, suprapubic pressure, or certain foods, or even emotional stress. You're going to see decreased pain with voiding, though that pain decrease is temporary. Our treatment's going to be nutritional and drug therapies combined with stress management strategies, tricyclic antidepressants, analgesics, antihistamines, physical therapy, Botox, or even surgery in the case of debilitating pain. We want to complete a careful pain assessment with dietary and lifestyle factors that increase or decrease with pain. We want bladder and voiding log for 3 days that includes a pain record. Also, monitor for UTI with diagnostic studies. Also, monitoring nutrition, avoiding restrictive clothing, coping strategies, and reassurance as well. Immunologic disorders of the kidney. Glomerulonephritis, or inflammation of the glomeruli. It could also be related to tubular and interstitial changes, vascular scarring, and hardening that affects both kidneys. It's the third leading cause of end-stage renal disease in the United States, and is often associated with conditions like kidney infections, nephrotoxic drugs, immune disorders, or systemic diseases. In the case of acute post-streptococcal glomerulonephritis, this is a common type of acute glomerulonephritis, common in children, young adults, and adults more than 60 years old. It develops 1 to 2 weeks after an infection of the tonsils, pharynx, or skin by nephrotoxic strains of different streptococci strains. The exact mechanism is unknown. The clinical manifestations will be generalized edema, hypertension, oliguria, hematuria, varying degrees of proteinuria or fluid retention. There could also be periorbital edema first, it then progresses to total body, including ascites and peripheral edema. They may also present with a smoky urine, bleeding in the upper urinary tract, proteinuria that varies with a glomerular nephropathy, hypertension that increases the extracellular fluid volume, and abdominal or flank pain. Could be asymptomatic, though found on routine assessments. In the case of acute post-streptococcal glomerulonephritis, again, history and physical, decreased complement components, renal biopsy for confirmation, and dipstick urinalysis and urine sediment microscopies. 95% recover completely or improve with conservative treatment. It's important to recognize or can progress to chronic glomerulonephritis. The management is going to be symptom relief, including rest with decreased inflammation and hypertension, restricting sodium and fluids, restricting protein, and antibiotics if streptococcal is present. For prevention, early diagnosis and treatment of sore throats and skin lesions. We don't want any infections to have a chance to spread, go systemic, and reach the kidneys. Chronic glomerulonephritis is a syndrome of permanent and progressive renal fibrosis that can progress to end-stage renal disease. The symptoms develop slowly, so the patient's often unaware until significant damage has been done. For chronic glomerulonephritis, the manifestations are hematuria, proteinuria, urinary excretion of formed elements, as well as increased BUN and creatinine. For rapidly progressive glomerulonephritis, this is glomerular disease with a glomerular crescent formation and a loss of renal function in days to weeks. It occurs as complications of inflammatory or infectious disease, as well as complications of systemic diseases or idiopathic diseases. Manifestations are hypertension, edema, proteinuria, hematuria, and red blood cell casts. Nephrotic syndrome. This is where the glomerulus is permeable to plasma protein, causing proteinuria leading to low albumin and edema. For treatment, our goals are going to be to cure or control the primary disease and relieve the symptoms. It could be done with corticosteroids, cyclosporins, ACE inhibitors, anti-hyperlipidemic drugs, atorvastatins, anticoagulants, low sodium, moderate protein diet with small frequent meals. Obstructive uropathies. A urinary obstruction is the anatomic or functional condition that blocks or impedes the flow of urine. It could be congenital or acquired, and deal with the damage that occurs at the level of obstruction. The severity depends on the location, duration, amount of pressure or dilation, and the presence of urinary stasis or infection. Here on figure 45-3, we just have a diagram showing the sites and causes of the upper and lower urinary tract obstructions. Obstructive uropathies may occur at the bladder neck or prostate due to detrusor muscle hypertrophy and eventual large residual urine. It may also occur at the bladder outlet with increased pressure with filling or storage. Here on figure 45-4, we have hydronephrosis of the kidney. Note the marked dilation of the pelvis and the calyces, as well as the thinning of the renal parenchyma. There may be a partial obstruction of the ureter or the uteropelvic junction. This would result in low to moderate pressure, as the kidney dilates without noticeable loss of functions. Urinary stasis and reflux may occur that increases the risk of pyelonephritis. Both kidneys or only one functioning kidney may be involved, with changes in the renal function occurring and the BUN and creatinine begin to increase. It could be the result of a urinary tract calculi or nephrolithiasis, a kidney stone. In the United States, 13% of men and 7% of women are eventually affected. Middle age, the risk increases as the patient gets older. It also occurs more frequently in whites and those with a family history. In the southeastern United States, followed by the southwest and the Midwest. Summer is also the more common cause due to dehydration in the hot weather. Risk factors for kidney stones may be metabolic, climate-based, dietary, genetic, or lifestyle. And they could all occur due to a concentration of supersaturated crystals that precipitate in the form of stones. Among the stone formation influencing factors are urinary pH. A higher pH causes calcium and phosphorus to be less soluble, while a lower pH, uric acid and cysteine are less soluble. They could also do with the solute load, inhibitors in urine, obstruction with urinary stasis, an infection with urea-splitting bacteria, or stress or infected stones. There are 5 categories of stones: calcium oxalate, calcium phosphate, cysteine, struveite, or uric acid. Calcium stones are the most common, though they may be mixed within various locations. The first symptom is going to be a sudden severe pain, a renal colic. These occur in the flank area, back, or lower abdomen. As the ureter stretches, dilates, and spasms, pain occurs. You may also see nausea and vomiting as the kidney stone dance, dysuria, fever, chills, moist, and cool skin. Common sites of obstruction are the uteropelvic junction or the uterovesical junction. Our diagnostic studies would include a non-contrast helical CT scan, ultrasound, urinalysis, or a 24-hour urine. There are 2 concurrent approaches. One is to manage the acute attack, focusing on pain, infection, and the obstruction itself. The second will be to evaluate the cause of the stone formation and prevent further development. Treatment and patient teaching would involve adequate hydration, sodium restriction, dietary changes, and drugs that could alter the pH of the urine, prevent excess urinary secretion of a substance, or correct the primary disease. For interventions, stones of 4 millimeters or less may pass spontaneously, though that could take weeks. They may also be broken up or treated with things like a lithotripsy to break up the stone, or even an open surgical stone removal. That may be considered if the stones are too large to pass, such as more than 7 millimeters, are associated with bacteria or symptomatic infection, impair the renal function, or cause persistent pain, nausea, or paralytic ileus. Other procedures may be a cystoscopy to go in there and remove the stone in the bladder, a cystolithopaxy, where large stones are broken up with a lithotrite, a stone crusher, or there could be a cystoscopic lithotripsy, that ultrasonic waves that break up the stones. They actually put the patient in a big tub and send the sound waves through to break the stones apart. Ultrasonic, laser, or electrohydraulic lithotripsies could also be used to break stones during that flexible uteroscopes, where removal of stones from the renal pelvis and upper urinary tract occurs. Also, percutaneous nephrolithotomies, where a nephroscope is inserted through the skin into the pelvis of the kidney, and the stones are fragmented and removed, followed by irrigation. A lithotripsy is a procedure to eliminate stones from a urinary tract, and that could come in many ways: laser lithotripsies, or that extracorporeal shockwave lithotripsy that we talked about. Following these procedures that break up the stone, a uteral stent may be placed to facilitate the passage of sand and could be removed in 2 weeks. Post-procedure hematuria and prophylactic antibiotics are expected. Complications, while rare, include hemorrhage, infection, or further obstruction. The primary indicators for surgery include pain, infection, and obstruction. And the type of surgery depends on the location of the stone, whether it's in the kidney, renal pelvis, ureter, or bladder. In the case of obstructing stones, we want to provide adequate fluids to avoid dehydration, as well as forcing fluids is not recommended as it could increase the pain. After a urolithiasis, we want high intake to produce 2.5 liters of urine a day. Water's the best. It prevents that supersaturation of minerals. It also works to reduce the risk of dehydration. Remind the patient to limit colas, coffee, and tea as they could increase stone formation. For our subjective data, we want a thorough past history with medications and surgery or other treatments. We'll focus our objective assessment on that thorough general, then a focused integumentary, gastrointestinal, urinary, as well as possible diagnostic findings based on what we see in our assessment. Our nursing diagnoses may include impaired urinary system function, acute pain, a lack of knowledge, as well as goals of having the patient with urinary stones see a relief of pain, no urinary obstruction, and have other knowledge of ways to prevent further recurrence. When preventing recurrence, we want lifestyle changes, as well as those dietary considerations like adequate fluid of up to 3 liters a day, if no cardiovascular or renal compromise would prohibit that level of fluid intake. We also want them to produce 2.5 liters of urine a day, and increase that even further if they're very active. Ureteral strictures can affect the entire length of the ureter from the upper to the lower, and the causes could range from congenital adhesions, scar formation, or a large tumor in the peritoneal cavity. They're going to clinically manifest for as mild to moderate colic or flank pain. Ureteral strictures are those fibroses or inflammation of the urethral lumen that leads to a narrowing and a compromised opening and closing with the bladder filling and voiding. Causes range from trauma, urethritis, surgical interventions, or repeated catheterizations. Could even be a result of congenital defects as well. Manifestations could include straining to void, a urine stream that's diminished, sprayed, or split, a post-void dribbling, an incomplete bladder emptying, frequency, or nocturia, and in severe obstruction could even result in urinary retention. The treatment's going to be a dilation with metal instruments or stents of increasing size, though in this case stenosis may occur. Self-catheterization every few days may also be required. Renal trauma. In the case of renal trauma, blunt injuries are the most common, ranging from abdominal, flank, or back injuries, sports injuries, motor vehicle accidents, or even falls. Next would be penetrating injuries, such as from violence, gunshots, stabbings, though all would have a clinical manifestation of hematuria. The treatment depends on the severity and would include bed rest, fluids, and analgesia. May also be required to have exploratory surgeries and repair, or even a nephrectomy where the kidney is removed. Nephrosclerosis. This is a sclerosis of small arteries and arterioles of the kidney that causes reduced blood flow, ischemia, interstitial fibrosis, and necrosis. In benign nephrosclerosis, this is age-related with more than 60 years old. The changes are usually due to hypertension and atherosclerosis. In accelerated or malignant nephrosclerosis, this is a medical emergency due to severe hypertension. Polycystic kidney disease is one of the most common life-threatening genetic diseases in the world, In the United States, it affects up to 600,000 people and is the fourth leading cause of end-stage renal disease. It has a genetic link with two hereditary forms. In adult, it's the autosomal dominant in 90% of cases, and in children, it's the autosomal recessive. Adult polycystic kidney disease affects both kidneys in men and women. The cortex and the medulla are filled with thin-walled cysts that destroy the surrounding tissue by compression. The cysts are filled with fluid and may have blood or pus within them. Signs and symptoms develop at 30 or 40 years of age, with clinical manifestations ranging from initial hypertension, hematuria, pain or heavy feeling within the back, and side or abdomen pain as well. Here in figure 45-7 from the textbook, on the left A, we have a comparison of the polycystic kidney with a normal kidney, and in diagram B on the right, we have the cysts shown within the liver. In adult polycystic kidney disease, the kidneys are enlarged and may be palpable. This affects the other structures, including the liver, heart, blood vessels, and tendons, and even brain. For diagnostic studies, we're going to use imaging like ultrasound and CT scan. They'll also consider our clinical findings and family history. There is no cure, though we can work to prevent and treat UTIs, as well as consider things like a nephrectomy, or even dialysis and kidney transplant. Tumors of the urinary tract. Kidney cancer. In the United States, there are 63,340 new cases each year, of which 14,970 people die. A renal cell carcinoma is the most common form, and they occur in males more often than female, with an average age of 64 years old. The risk factors include cigarette smoking, obesity, hypertension, exposure to asbestos, cadmium, or gasoline. Here in figure 45-8, we just have a diagram showing a renal cell carcinoma there with the arrow. In the early stage, they are asymptomatic and often incidental finding for unrelated condition. 25% have metastasis when diagnosed. The common manifestations include hematuria, flank pain, a palpable mass in the flank or abdomen. It may also include weight loss, fever, hypertension, and anemia. Prevention should focus on smoking cessation, maintaining a healthy weight, controlling blood pressure, avoiding exposure to toxins, identifying high-risk groups, and patient teaching focusing on early manifestations and symptoms to be on the lookout for. Interprofessional care would involve staging ranging from 1 to 4, with early detection having a higher chance of cure. Treatments would include surgeries, ablations, immunotherapies, and targeted therapies. Moving on to bladder cancer, it is the most common urinary system cancer, with 81,900 new cases diagnosed each year and 17,240 deaths. They occur more commonly in older adults and those aged over 55, accounting for 90% of cases. The transitional cell cancer is the most frequent, and risk factors again include cigarette smoking, as well as industrial exposure to dyes and other chemicals. Here in figure 45-9, on figure A on the left, we have a papillary transitional cell cancer, seen arising from the dome of the bladder as a cauliflower-like lesion. And then in figure B on the right, we have that open bladder showing advanced stage bladder cancer. The yellow areas are ulcerations and necrosis. The most common manifestations are microscopic or gross painless hematuria, with dysuria and frequency and urgency also being other symptoms. For diagnostic studies, we'd include urine specimens for cancer or atypical cells, as well as CT scans, ultrasounds, or MIs to get a visual on it. The cancer is graded in stage from 1 to 5 before treatment, with most diagnosed early. The staging is determined by the depth of the invasion of the bladder and the surrounding tissue, with treatments including surgery, radiation, or chemotherapy. The patient may also receive a transurethral resection of the bladder tumor, where superficial lesions are removed with a cystoscope. They may also receive a segmental or partial cystectomy, where they remove the large tumors in one area of the bladder wall and margin of normal tissue. Or, should it be severe, there could also be a radical cystectomy, where invasive tumors or trigon areas, but see no metastasis beyond the pelvic area. They must have a urinary diversion for this to take effect. In postoperative care, the patient needs to drink a large volume of fluid for 1 week and include patient teachings to monitor the color and consistency of the urine. And it may be pink for several days, but make sure that it's not bright red or showing up with a lot of clots. The patient may also receive radiation, either as a primary therapy or in combination with a cystectomy. Chemotherapy drugs or immunotherapy may also be considered. Local installation of immunotherapy or chemotherapy by a urethral catheter. This is going to be retained for 2 hours and have the patient change position every 15 minutes. There may also be weekly intervals for 6 to 12 weeks. The patient may receive induction and maintenance therapy as well. Bladder dysfunction. The most common would be urinary incontinence. This is the involuntary leakage of urine. It's more prevalent with older adults and in women more than men, but is not a natural consequence of aging. While with men, it's usually due to BPH or prostate cancer, with an overflow of incontinence from that urinary retention, whereas with females, it usually takes the form of stress or urge incontinence. By its etiology, this is a bladder pressure greater than the urethral closure pressure can handle, and it results in an interference with the bladder or sphincter control. There's also the acronym DRIP, D standing for delirium, dehydration, or depression, R standing for restricted mobility or rectal impactation, I standing for infection, inflammation, or impaction, MP for polyuria or polypharmacy. Again, there's many different forms of urinary incontinence: stress, urge, overflow, reflex, incontinence after trauma or surgery, functional incontinence, and the patient may have one type. In this case, it would be called a mixed incontinence. We begin with a basic evaluation, including a bladder log or voiding record for 1 to 7 days. This would include everything from onset, provoking factors, and associated conditions. We'd then move on to a physical exam, including a general and functional issues, as well as a thorough pelvic exam. There'd also be diagnostic studies, such as urinalysis, to identify any infections. Fortunately, many cases can be cured or improved, including to treat the transient reversible factors first, and identify interventions depending on the type and underlying cause of the incontinence itself. Our surgical therapy is going to depend on the type of incontinence. They could look at considerations like a urinary structural support or repositioning, or an increased urethral resistance of internal sphincter, or an intra-abdominal pressure reception. Other interventions could include a suburethral sling, bulking agent injection, or an artificial sphincter surgery. Incontinence can be embarrassing. We really want to identify any physical as well as emotional concerns the patient may have and help them to maintain the dignity, privacy, and self-worth. It's got to be difficult dealing with incontinence, though there are many different options for treatment. Urinary retention is an inability to empty the bladder with voiding or with the accumulation of urine because of an inability to void. It may be associated with leakage or post-void dribbling. In acute urinary retention, this is an inability to pass urine and isn't a medical emergency. For chronic urinary retention, this is incomplete emptying despite urination. In the case of a bladder outlet obstruction, the bladder can't empty due to severe blockage. For men, this is due to an enlarged prostate. There may also be deficient detrusor contraction, where the muscle can't contract enough to force or time to empty the bladder. This could also be secondary to neurologic diseases involving the sacral second, third, or fourth nerve, diabetes, overdistension, chronic alcohol use, or anticholinergic drugs. Our diagnostic studies would be the same as with urinary incontinence, where urinalysis, post-void residual, urodynamic studies, and ultrasound are used. We may also include interprofessional care for behavioral therapies, toilet scheduling, double voiding, and catheterization. For surgical therapies dealing with the obstruction, we may look at transurethral or open techniques such as a prostate enlargement, or abdominal or transvaginal approaches such as a pelvic organ prolapse. There may also be surgical therapies dealing with the deficient detrusor contractions. Acute urinary retention is a medical emergency. We need to insert a catheter, maybe even consider an indwelling catheter to relieve this pressure quickly. We're also going to include patient teachings to minimize the risks, such as drinking small amounts throughout the day, being warm when trying to void, and avoiding excess alcohol. The patient teachings, if they are unable to void, would also be drink caffeinated beverages or tea to increase the urgency, take a warm bath or shower, and seek medical care. In the case of chronic urinary retention, we're going to look at behavioral methods first, such as scheduled toileting every 3 to 4 hours, before moving on to things like catheterization, surgery, or drugs. As we discussed before, preventing CAUTI is going to be a top priority. Those catheter-associated UTIs are extremely dangerous, and we want to determine the need for the catheter, and the healthcare provider must provide an order. We also want to be careful to choose the appropriate size and type of catheter. Insert the catheter in the patient with the urethral trauma, pain, or obstruction. Develop a plan of care to decrease the risk of infection. Teach catheter care to the patient, especially if ambulatory, and make sure to always use a sterile, closed drainage system. Also, remember to never disconnect the system except for when irrigating. We want to also use sterile technique if the need is there to use an open system, and consider a triple lumen catheter for continuous irrigations. A catheter change may not be necessary if less than 2 weeks, or for long term. Determine the necessity based on the assessment, not routine. Also, use catheter sampling port for urine cultures, and prepare a puncture site with aseptic solution. Also, we want to use a leg bag for long-term catheter use, or if reusing the collection bag, clean it thoroughly. Also, remove the catheter as early as possible. There are fewer cases of bacteria or CAUTI with intermittent catheterization and external catheters. Surgery of the urinary tract. There's different forms of surgery of the urinary tract. There could be renal and ureteral surgeries, and the indication for nephrectomies, renal tumors, bleeding, or infected polycystic kidneys, massive trauma, or donor transplants. They could be surgical procedures involving open or laparoscopic. In open, they are 6 to 10 inch incisions in the flank or abdomen, whereas with the laparoscopic, it's a 3 to 5 inch puncture. In preoperative management, we want to identify the patient's basic needs and ensure that they have adequate fluids and normal electrolytes. The patient may also have pain from positioning in the OR, so we need to make sure that we're prepared for that. During postoperative management, we want to monitor the urine output closely, measure and record Q1 and Q2 hour total outputs, and note the color and consistency as well as the catheter patency in the patient's daily weights. We also want to closely monitor the patient's respiratory status. A nephrectomy flank incision can be painful. Administer analgesia so the patient can participate with turning, coughing, and deep breathing with as little pain as possible. We also want to be very aware of abdominal distension, monitoring for paralytic ileus, checking bowel sounds, and providing IV fluids before we progress them up to oral fluids when the bowel sounds return. Urinary diversion. This is used when urine flow is blocked from bladder cancer, neurogenic bladder, congenital anomalies, strictures, bladder trauma, and chronic bladder inflammation. And the types of surgery procedures used for diversion will depend greatly on where it is blocking it. Here in figure 45-11, we just have a diagram of the different methods of urinary diversion. In figure A on the left, we have a uretero-iliosigmoidostomy. Say that 5 times fast. Or in figure right on the B, we've got an ileal loop, or sometimes called an ileal conduit. Then here in figure C on the left, we have a ureterostomy, where in figure D on the right, we have a nephrostomy. In the case of a diversion to the skin, they must wear an appliance, the most common being an ileal conduit or ileal loop. In this case, the ureters are connected to the conduit, and the bowel may also be brought to the abdominal wall to form a stoma. There's no valve and there's no voluntary control. The urine drips into that external collection bag. Here in figure 45-12, we just have a photo of that urinary stoma. You'll notice that it's symmetrical, there's no skin breakdown that protrudes about 1.5 centimeters. The mucosa is healthy red, and this configuration is flat when the patient is upright or supine. The patient may also have an intra-abdominal urinary reservoir that can be catheterized and has an internal pouch. The reservoir is constructed from ileum or ascending colon, and it's surgically created valve and a large, low-pressure reservoir that prevent involuntary leakage with no external collection device. Here in figure 45-13, we have a coke pouch. The creation of a coke pouch is with the implantation of ureters into one intuscepted part of the pouch and the creation of a stoma with the other intuscepted part. For preoperative management, we're going to focus on patient and family education. Also, the psychosocial support, including anxiety, fear, living with the stoma, as well as dealing with incontinence. In postoperative, we're going to focus on preventing complications such as atelectasis, shock, thrombophlebitis, small bowel obstruction, paralytic ileus, or UTI. We also want to prevent stoma injury and maintain urine output. We're also going to focus on meticulous skin care and avoid alkaline incrustations with dermatitis and yeast infections, as well as be on the lookout for product allergies and the shearing effect of excoriations. Changing the appliance is going to take practice for the patient. Also, continent diversion and patient teaching, such as how and when to catheterize and irrigate. In the case of an orthotopic bladder, they're going to catheterize for postoperative urinary retention. Bladder control may take up to 6 months. Emptying the bladder every 2 to 4 hours by relaxing the outlet sphincter and bearing down with abdominal muscles. The patient does not feel the need to void. Finally, we're going to focus on body image. Encourage the patient to share their feelings and concerns, as this is going to take one of those issues that the patient is going to have to get used to, and it may take a little work on the patient's part to get used to it. For discharge teaching, focusing on that ileal conduit, the symptoms of obstruction or infection, how to perform ostomy care, and notifying them that the stoma may shrink as it heals. But anyway, that's all we got for this chapter. I'll see you in the next slides.